طب صباح الخير يا جماعة، إحنا هنبتدي دلوقتي أول session الocular emergency. Now we are listening to Dr. George. He will talk about trauma and endophthalmitis. Dr. Khalid Fadl will talk about acute retinal detachment, orbital compartments.
Good morning, teachers and colleagues. I'm Dr. Khalid Al-Jabali. I'll be talking about two topics today, starting with the retinal detachment. Okay. So RD refers to separation of neurosensory retina from the RPE, which result of accumulation of subretinal fluid in the potential space between the neurosensory retina and the RPE. There are three types: rhegmatogenous, tractional, and exudative. The first one, the rhegmatogenous, which requires a full thickness defect in the sensory retina, which permits fluid derived from liquefied vitreous to gain access to the subretinal space. So it's mainly secondary to retinal tear. And it is said to be present when fluid extends further than 1 optic disc diameter from the edge of the break. The symptoms: we have flashes of light, floaters, curtain or shadow moving over the field of vision, peripheral or central vision loss, or both. We have in the signs elevation of the retina from the RPE by the fluid in the subretinal space, relative afferent pupillary defect, which is present in extensive RD. The intraocular pressure to be lower by about 5 millimeter of mercury compared to the other eye. There might be as well iritis, tobacco dust, which consists of pigment cells and is commonly seen in the anterior vitreous. Retinal breaks, which appear discontinuities in the retinal surface. The second type, which is tractional, and here the neurosensory retina is pulled away from the RPE by contracting vitreoretinal membranes in the absence of retinal break. And the causes of it, it's mainly the fibrovascular membrane in the vitreous result from proliferative diabetic retinopathy, sickle cell retinopathy, retinopathy of prematurity, toxocariasis, trauma, or vitreoretinopathy. We have in the symptoms visual loss or visual field defect, and maybe sometimes asymptomatic. In the signs, we have RD, which has a concave configuration, and breaks are absent. Retinal mobility is severely reduced, and shifting fluid is absent. The subretinal fluid is shallower than in the rhegmatogenous and seldom extend to the ora serrata. The highest elevation of the retina occurs at sites of vitreoretinal traction, and on B-scan, ultrasonography shows incomplete PVD and relative immobile retina. For the third type, we have the exudative, which is a subretinal fluid is derived from the vessels of the neurosensory retina and or from the choroid in the absence of retinal break or traction. We have the etiology for it: choroidal tumors, inflammations, central serous choroidal retinopathy, iatrogenic due to surgery, or choroidal neovascularization, hypertensive choroidopathy, and idiopathic. And for the symptoms, we have visual field defect with varying degree of vision loss, and visual changes may vary with changes in the head position with the movement of the fluid. The floaters may be present if there is any associated vitritis. And the signs, we have a convex configuration, and the surface is smooth and not corrugated. And we have a phenomena of shifting fluid of the subretinal fluid, and Libert spots, which consist of scattered areas of subretinal pigment clumpings and may be seen after detachment has flattened. And the workup, we have slit lamp examination to assess for signs of uveitis, lens status, presence of vitreous pigment, or hemorrhage, and posterior vitreous detachment. And we use indirect ophthalmoscope with scleral depression for both eyes. Slit lamp examination with 90D lens or wide lens may help in finding small pricks. We use B-scan or ultrasound for if the media opacity are present. Intravenous fluorescein angiography may demonstrate leakage or pooling and identify the source of subretinal fluid in the serous RD. And the OCT is useful to identify tractional membranes and can be useful to differentiate tractional membranes from detached retina. For the treatment for serous retinal detachment, we usually treat the cause, so in some cases resolve spontaneously, whilst the other treated with systemic corticosteroids, such as Harrod disease and posterior scleritis. In some eyes with central serous retinopathy, the leak in the RPE can be sealed by laser photocoagulation. And patient with an acute RD that threatens the fovea should have surgical repair performed urgently. The visual prognosis is significantly worse in detachments that progress to involve the fovea. Surgical options include laser photocoagulation, cryotherapy, pneumatic retinopexy, vitrectomy, and scleral buckle. For the second topic, we have orbital compartment syndrome. It's an ophthalmic emergency, and it's vision-threatening elevation of intraorbital pressure that exceeds vascular perfusion pressure of the ophthalmic artery. It can result in ischemia and irreversible vision loss if not corrected emergently. It is most commonly caused by orbital or facial trauma, and the most usually common associated with retrobulbar hemorrhage. However, any process that results in an increase in the volume within the orbit can lead to orbital compartment syndrome. There are other causes, such as local injections, orbital infections with or without abscess, orbital emphysema, foreign bodies, spontaneous hemorrhage, fluid resuscitation after burn injuries, thyroid eye disease, rapidly enlarging tumors of the orbit. We have in the symptoms pain, decreased vision, inability to open the eyelids due to severe swelling, recent history of trauma or surgery to the eyelid or orbit, history of anticoagulation, ischemia to the optic nerve, globe, and retina occurs, potentially resulting in devastating permanent visual loss. In the signs, we have proptosis with resistance to retrobulging, tense rock hard eyelids that are difficult to open, vision loss, afferent pupillary defect, dyschromatopsia, and increase in intraocular pressure. There might be other signs like eyelid ecchymosis, diffuse subconjunctival hemorrhage, chemosis, congested conjunctival vessels, evidence of disc swelling from compressive optic neuropathy or retinal vascular occlusion, limited extraocular motility in any or all fields of gaze. We have multiple differential diagnoses. We have orbital cellulitis, where we can find fever, which is differentiated by fever, severe orbital emphysema, where we can hear the crepitus, orbital fracture, which would have limited extraocular motility, high flow direct carotid cavernous fistula. We can find pulsating exophthalmos with ocular bruit, and varix, which characterized by increased proptosis with Valsalva maneuver. Sometimes there is other diseases that could be differentiated, lymphangioma in younger patients, or spontaneous retrobulbar hemorrhage, especially in patients with anticoagulation or hematological disease such as hemophilia. For the workup, we have an ophthalmic examination must be done and check specifically for any afferent pupillary defect, loss of color vision, check degree of tightness of the eyelid and resistance to retrobulging, raised intraocular pressure, check for the globe rupture. If fundus examination can be done, pulsation of central retinal artery, choroidal pulse, and optic nerve edema should be looked for. We do CT orbits, but sometimes it should always be delayed until definitive treatment with canthotomy and cantolysis is done. And on the radiology, we see teardrop tinting sign on the back of the globe, which is an ominous radiological sign, especially if the posterior scleral angle is more than 130 degrees. The presence of an orbital fracture may help to decompress the orbit, but not rule out possibility of ocular orbital compartment syndrome. And it's important to remember that patients can still develop orbital compartment syndrome and optic neuropathy even with large orbital fractures, as blood may simply fill the adjacent paranasal sinuses and then cause orbital compartment syndrome. The key to effective management of clinically significant retrobulbar hemorrhage with orbital compartment syndrome is timely and aggressive soft tissue decompression. The initial goal is to decrease the compression on critical soft tissues, mainly the optic nerve. If optic neuropathy is present, treatment should be started immediately if progressive visual deterioration can occur. And canthotomy alone is rarely adequate, so it's done along with cantolysis. The goal of canthotomy and cantolysis is to perform the adequate of soft tissue decompression to the orbit by inserting the lower eyelid from its periosteal attachments. If there are no orbital signs and no evidence of ocular ischemia or compressive optic neuropathy, but the IOP is increased, patient should be treated in more stepwise fashion to lower the IOP. Thank you.
Thank you, Dr. Khaled. If you can slow down.
ده بيعلى شويه لفوق يا جماعه.
امسكوا.
Good morning, everyone. I'm Dr. Ahmed Aktham, and today I'm going to speak about two important ocular emergencies, which are the acute angle-closure glaucoma and severe orbital cellulitis. Before I start, I have to mention that all images are generated by AI for educational purposes, and no real patients are depicted. So it was the lucky hour when we got two patients at the same time to our ER. The first patient is 62-year-old woman presented with sudden, severe, painful red eye and headache. Also, she had blurry vision, halos, and she was vomiting. The second patient is a 9-year-old boy with progressive eyelid swelling, eye pain, and fever. Also, he has, as you see, proptosis, blurry vision, and painful eye movements. Starting with the 9-year-old boy, as I've mentioned, he has eyelid swelling, proptosis, and by examination, we found chemosis, painful restricted eye movement, decrease in visual acuity, and high-grade fever and malaise. So when we have this triad of proptosis, fever, and extraocular muscle pain, please consider orbital cellulitis until proven otherwise. So let's step back to basics and review some important aspects. Regarding the definition of orbital cellulitis is that it is a sight and life-threatening infection of soft tissues posterior to the orbital septum. The most common cause is sinusitis, especially ethmoid, also trauma, dental infections, hordeolum, and dacryocystitis. One of the important classifications here is the Chandler's classification, which grades the severity of orbital infections based on anatomical spread. It is a 5-grade classification, starting with preseptal cellulitis and ending with cavernous sinus thrombosis. So in order to confirm the diagnosis, we have to do an urgent CT with contrast for the orbit and the paranasal sinuses. Also, an MRI can help for identification of cavernous sinus thrombosis or intracranial extension. Also, in order to confirm that this is an infection and inflammation, we have to do the routine workup of CBC, CRP, ESR, also blood cultures and drainage cultures to identify the best antibiotic course. As you can see in these two photos, the photo on the left, we have an axial CT with contrast showing right orbital subperiosteal abscess. Please note the arrows, secondary to ethmoidal sinusitis with associated proptosis. The right picture shows a coronal T1 MRI demonstrating left orbital cellulitis with fast stranding proptosis and adjacent ethmoidal sinusitis, as you can see. So what is the differential diagnosis? Starting with preseptal cellulitis, obviously, and also we have thyroid eye disease, orbital pseudotumor, cavernous sinus thrombosis, and orbital tumor. Okay, what if we delay? Unfortunately, this will lead to optic nerve, optic neuritis, and then orbital abscess, and then cavernous sinus thrombosis, and ending with intracranial abscess. So this is not just about saving sight, it is about saving life. So what is the management? The first and most important thing is to admit immediately, and then start the course of IV antibiotics, and we can add metronidazole if any ropes are suspected. Also, supportive care is important, fluids, antipyretics, frequent visual acuity checks. Drainage in case of abscess, when it is more than 10 millimeters, if there is a drop in visual acuity, rapid or no improvement in 48 hours. The second patient is a 62-year-old woman, as you can see in this photo generated by AI, that a doctor that supposedly looks like me is examining the patient. The patient, as I've mentioned before, have severe ocular pain, red eye, blurred vision, and halos, and came presented with nausea and vomiting. On examination, on a slit lamp, we found that she has corneal edema, mid-dilated fixed pupil, shallow AC, and the IOP was 48. So diagnosis is built on the triad of clinical findings, IOP measurements, and gonioscopy if available, and this gives us a diagnosis of acute closed-angle glaucoma. And please note that if you have a red eye and the patient is vomiting, please immediately check pupil and IOP. Let's also step back to basics and discuss some points. The first thing is that definition is that it is a sight-threatening emergency due to sudden angle closure and blocked aqueous outflow. The etiology, as we know, that hyperopia is a factor for this, also shallow AC and narrow angle. The triggers, which are very important to take care of, dim lighting, mydriatics, stress, antidepressants, and antihistaminics that can cause acute angle closure glaucoma. Also regarding the types, we have primary and secondary. The primary is because of an anatomical factor. And secondary, the angle is closed due to new vascularization, like the 100-day glaucoma. Also, chronic uveitis can close the trabecular meshwork. The phacomorphic glaucoma, the aqueous misdirection, which is the malignant glaucoma, and also choroidal causes like choroidal effusion, choroidal hemorrhage, and choroidal tumors. So what is the differential diagnosis? We have here conjunctivitis, acute anterior uveitis, scleritis, corneal abrasion, and migraine. So again, what if we decided to delay? Unfortunately, we will have the patient will go into an optic nerve ischemia, irreversible vision loss within hours, and also the fellow eye is at risk if unprotected. So please act within the golden hours. So what is the management? This management is according to Will's Eye Manual. First thing, please start immediately these topical drops. 3 rounds at 15 minutes intervals. Timolol, brimonidine, dorzolamide, pilocarpine if the IOP is below 40, because above this, the muscles will be in a ischemic state, so no, it is not useful. Also, prednisolone acetate for treating the inflammation and the corneal edema. Also, the systemic treatment, which is very important, to give acetazolamide 500 milligrams intravenous immediately, or 2 tablets of 250 milligrams. Please recheck the IOP in 1 hour, and then if the IOP is still high, please administer IV mannitol 20%, and if not available, please give the patient oral glycerol. Additional measures are analgesics, antiemetics, also compression gonioscopy if you can. The definitive treatment is always YAG, laser peripheral iridotomy for both eyes once cornea clears. And if there is a synechial angle closure, we might require a surgical option. So to sum up, this table shows or highlights the important points we discussed in this presentation. I want to emphasize that acting fast is important. Regarding the orbital cellulitis, please admit the patient immediately, give IV antibiotics in order to prevent complications. And for the acute angle closure glaucoma, please lower the IOP immediately. And please don't forget that laser PI is done for both eyes, not just the affected one. Thank you.
Thank you, Dr. Ahmed, and thank you for using AI in your presentation, because we are in the era of AI. Now is Dr. George, finally.
يعني فعلا بتخلينا يعني we feel proud of you فعلا يعني thank you so much لكلكم والله لحد دلوقتي. هي بس الكومنت صغير على اخر حاجه الاكسم، هو في ال acute angle closure طبعا انت حاطط الكلاسيك مانجمنت، بس لازم we shouldn't forget ان هو دلوقتي primary treatment almost of acute angle closure is surgical lens extraction. We have to consider this مش glaucoma surgery كمان.
Good morning, everybody. We are going to talk about 2 types of medical emergency today. The first one is penetrating globe trauma. First, penetrating injury is by definition are caused by a sharp object that penetrates into the eye.
Symptoms, history of trauma, fall, sharp object entering the globe. A patient might be presented by pain, decreased vision, photophobia, loss of fluid from the eye. Upon examination, we might find full thickness scleral or corneal laceration, severe subconjunctival hemorrhage, deep or shallow AC compared to the fellow eye. We also might find peaked or irregular pupil, a lens material or vitreous in the AC, cataract, foreign body tract, or new opacity in the lens. Less commonly, lower intraocular pressure, iridodialysis or cyclodialysis, hyphema, periorbital chemosis, vitreous hemorrhage, dislocated or subluxated lens. Commotio, choroidal rupture, and retinal breaks might also be seen, but often are obscured by vitreous hemorrhage. Diagnosis should be made immediately by pen light and direct ophthalmoscope, or if possible, slit lamp with minimal manipulation. Always examine the other eye. Once a ruptured globe is diagnosed, further examination should be deferred until the time of surgical repair in the OR. We have to avoid placing any pressure on the globe and risking extrusion of intraocular content. CT scan of brain in orbit, axial, coronal, and parasagittal views to rule out intraocular foreign body, like see in picture A. This is an intraocular foreign body. Gentle B-scan ultrasound may be needed to localize posterior rupture sites and to rule intraocular foreign bodies that are not visible on CT scan, and like non-metallic intraocular foreign bodies. However, B-scan shouldn't be done in patient with an obvious anterior rupture due to the risk of extruding intraocular content. Treatment, we have to arrange for surgical repair as soon as possible. Close the corneal and scleral wound by sutures. And in case of canalicular laceration, surgical repair should be done with the use of stent to improve the cosmetic outcome and overall results. After surgery, we have to start administrating a systemic antibiotic within 6 hours of injury. For adult, we can give cefazolin, 1 gram IV every 8 hours, or vancomycin, 1 gram IV every 12 hours, and moxifloxacillin, 400 milligram IV daily, or an equivalent fluoroquinolones. A week antibiotic course is typically completed post-operatively with a broad spectrum fluoroquinolones. Thank you. أنا كتبتها بس ما قلناش أنا قلتها بجد. Okay. Okay. And now to our second topic. Endophthalmitis. Endophthalmitis is defined as an intraocular inflammation which predominantly affects the vitreous and the anterior chamber. Symptoms could be presented with pain, redness, photophobia, loss of vision, conjunctival swelling. Upon examination, signs may vary according to severity, from eyelid swelling, chemosis, conjunctival injection, discharge, corneal haze, fibrinous exudate and hypopyon, vitritis with an impaired view of the fundus, severe vitreous inflammation with debris and loss with the red reflex. Types of endophthalmitis might be exogenous or endogenous endophthalmitis. Exogenous might be acute post-operative or chronic post-operative, traumatic, filtrating clip associated after intravitreal injection or corneal ulcer. Endogenous might be bacterial or fungal. Organisms, post-cataract extraction, most common Staphylococcus epidermidis, less common Staphylococcus aureus or strep, less common gram-negative bacteria, species including Pseudomonas, Proteus, Klebsiella, Bacillus, Haemophilus influenza, E. coli, and anaerobes. PLEP associated like Streptococcus or gram-negative. Post-vitrectomy, staph epidermidis. Post-intravitreal injection, staph epidermidis and oral floor. Differential diagnosis, toxic anterior segment syndrome. It might occur from 6 to 24 hours after cataract surgery with diffused corneal edema, KPs, due to endotoxin from surgical instruments or fluids. Usually respond to intensive topical steroid and cycloplegic therapy, but may require endothelial keratoplasty or penetrating keratoplasty for persistent corneal edema. Acute non-infectious uveitis flare. Ask about history of previous uveitis attacks. HLA-B27 associated anterior uveitis may be precipitated by trauma. Sterile endophthalmitis following intravitreal triamcinolone or anti-VEGF injection. Lens particle uveitis, retained lens fragments in the angle or vitreous or retained lens cortex in the capsular bag, and chronic post-operative uveitis. Workup, complete ocular history and examination. Look for wound or PLEP leak, exposed sutures, vitreous to wound, blepharitis, or other predisposing factor for endophthalmitis. Consider B-scan ultrasound if there is limited view to the posterior segment, which may confirm marked vitritis and or membrane formation and establishes a baseline against which the success of the therapy can be measured. If vision is light perception post-cataract extraction, a diagnostic and probably therapeutic vitrectomy is often indicated. Cultures and smears should be obtained and intravitreal antibiotic are given. If vision is hand motion or better, vitreous aspiration or an anterior chamber paracentesis if the vitreous specimen can't be obtained is performed and variably sent for culture. Prevention. Primary prevention is preparation of the conjunctiva with 5% betadine in all cases, and eyelid for incisional eye surgery prior to surgery has been proven to reduce the risk of endophthalmitis. Intraoperative intracameral antibiotics have also been shown to reduce endophthalmitis risk, while preoperative use of topical broad-spectrum antibiotic may decrease bacterial load. It hasn't been proven to lower the rate of endophthalmitis and may promote antibiotic resistance. Anterior chamber or vitreous tab for gram stain, culture, and sensitivities, along with timely intravitreal injection using broad-spectrum antibiotic. Consider intravitreal steroid in case of severe vitreous inflammation. Consider admission to hospital for observation and consider intensive topical steroid to control anterior segment inflammation. Consider intensive topical fortified antibiotic like vancomycin around the clock for 24 to 48 hours in the setting of filtrating blips, wound leak, or exposed sutures. Atropine 1% 2 to 3 times per day. For post-cataract extraction endophthalmitis, immediate pars plana vitrectomy is beneficial if visual acuity in presentation is light perception. Vitrectomy for other causes of endophthalmitis, PLEP-related, post-traumatic, or endogenous may be beneficial in selected cases. Systemic antibiotic might be considered. Intravenous antibiotic are not routinely used. Considered IV fluoroquinolones in special circumstances. Some oral antibiotics may reach therapeutic vitreous level and could be considered as alternative to intravenous antibiotic. Thank you.
Thank you, Dr. George. Thank you for all the speakers, and we reached the end of this session. Thank you.